Okay then, so why did we carry out this research in the first place? It was very much in response to the Integrated Care Systems, or ICSs, becoming NHS statutory bodies last year. So we decided to reach out to some of our thought leaders from the NHS who sit on the GKA panel and conduct some depth interviews to understand a little bit more about these new NHS structures. Now, trying to navigate the NHS can be an extremely complicated exercise at the best of times, and we wanted to find out how ICSs are taking shape from a leadership perspective, the impact on the front line from both a practitioner and patient perspective, and then what that means for the wider sector and market research. Now, I spoke with a number of senior leaders from the NHS, including a member of an Integrated Care Board exec team, a former CCG chief exec, a head of medicines management, and also a place lead director, all of whom work for a variety of different ICSs, and some have been operating for years prior to them becoming statutory bodies last year. Now, before I cover the journey to ICSs and the reforms that they aim to achieve, I think it's important to contextualise that these reforms are happening against the backdrop of a service recovering from the impacts of the COVID pandemic on both staff and growing patient waiting lists, staffing shortages across the NHS and social care, and a cost of living crisis. So that said, these reforms should in time ease pressures on the NHS, reduce bed blocking, and ultimately improve the general population's health. Now, our population is very different from when the NHS was first established, with individuals living much longer and experiencing multiple conditions, and this obviously creates greater demands on the NHS. Now, the current government have initiated 2 reform programmes during their administration, which have led to the current position of ICS and the statutory integration of health and social care. Now, this move aims to bring greater connections between all services that have a role in health management, health efficiencies, and general population wellbeing. A primary function of integrating these services is designed to increase efficiencies, reduce barriers such as bed blocking, and improve outcomes for patients by getting them into settings that are appropriate for them. Now, ICSs build on a number of reform programmes that I'm sure you're all familiar with, including the move from PCTs to CCGs before our current structure of ICSs. Now, these reform programmes aren't discarding lessons learned from previous programmes, but rather each time taking the ambitions to a new level and looking at elements that have emerged from existing programmes. Now, the most recent reform was introduced back in 2019 and built on the government's NHS long-term plan. At its core, ICSs were designed to integrate services across health and social settings and provide greater autonomy at a local level to drive health and well-being across communities. Now, in July 2022, statutory arrangements for the integrated care systems finally came into force. Okay, so let's just explore what an ICS actually is then. So ICSs are essentially partnerships that bring together NHS organisations, social care providers, local authorities and others to take collective responsibility for planning and delivering joined up health and care services. Now, in turn, they aim to improve the lives of people who live and work in their area and reduce inequalities across geographical areas. 42 ICSs have been established across England and are led by an integrated care board and an integrated care partnership. Now, to enable accountability within this structure, ICSs will operate at 3 levels. So firstly, there's the system level, and this will typically cover populations of approximately 1 to 2 million. The second level is place, and this usually covers a population of around about 250 to 500,000. And then finally, we have the neighbourhood level, and this usually covers populations of approximately 30 to 50,000. Now, these 3 levels of operation are designed to look at the whole population and identify healthcare needs and preventative action. So these area levels look at the different needs of populations within a region. So for example, where pockets of deprivation are impacting on health down to neighbourhoods, and where local reflection on healthcare priorities can be identified, actioned and shared. Also operating at these varying levels retains localisation but brings about healthcare efficiencies such as medicines buying at the system level. Whilst over the years we've seen NHS models move from centralisation to localisation and then back again, this latest reform is the first time that we've seen a significant move to integrate social care. Now, this has been further strengthened through the 2022 Health and Social Care Act, which introduced new legislative measures that aim to make it easier for health and care organisations to deliver joined-up care across the NHS. The thought leaders I interviewed explained differences in the timeframe that they've been operating as an ICS, and one area applied for ICS status over 5 years ago due to their struggling health economy under these CCG structures and the anticipated opportunities an ICS would present. Now, others, however, explained how their ICS was newly formed when they became statutory bodies last year, and that it's still very much early days for them, with activity focusing on practical changes such as setting up hierarchies and appointing people into roles to lead initiatives within the subcommittees.
A lot of it's just really practical hierarchy stuff, setting systems up and people, and and they're still going through that phase, sort of appointing people, trying to work out what to do with the 1,000 or so staff that transfer from CCGs. So most of the work from, say, when they became a statutory organisation in July, so it's only 2 or 3 months. Has been around the formalities of setting up hierarchies, boards, subcommittees, appointing people to lead various things.
And I see some of the other boroughs, in a way, really having to open their workbook and say, okay, chapter 1, integration 101, and say, what does this mean? Okay, we need 2 of those and 1 of those and 3 of those. We better find those people.
Although ICSs only became statutory bodies within the last 6 months, the NHS first started talking about its ambitions for integration long before this. And the reality is that they've been developing for several years now. So they evolved from Sustainability and Transformation Partnerships, or STPs, which were groupings of health and care organisations formed in 2016 to develop place-based plans for the future of health and care services in their areas, and were essentially the precursor to the ICS organisations. So from 2016 onwards, we all observed multiple CCG mergers as the initial steps to start consolidation of NHS organisations and to centralise resources in line with the NHS long-term plan. Now, by 2021, each STP or ICS footprint, which were still voluntary partnerships at that stage, involved either a single or a very limited number of CCGs in the run-up to ICSs becoming statutory bodies last year. Now, the reality of the situation is one of gradual transition to the ICS structure, which will come as no surprise to anybody here, I'm sure, as the NHS is not the most dynamic of organisations. This means that there were no significant overnight changes when ICSs became statutory bodies, but legislation has prioritised the changes needed to realise these new NHS organisation structures. Now, each of the 42 ICSs is now underway developing and publishing their 5-year strategic plans to explain how their partners will work together to deliver the ambitions of the NHS long-term plan and address the specific priorities, opportunities and challenges within their ICS area. Now, the pandemic has undoubtedly had an impact on the transition period, having surfaced during a critical time and slowing progress in many areas. However, the impact of COVID has not been all negative, and it has actually driven some change through the way that the NHS uses technology as an organisation. And therefore, it's actually been a catalyst to some of the ambitions of the NHS long-term plan, such as virtual consultations becoming much more widespread. Now, COVID also deflected the focus of the NHS, and some believe this also tempered the transition period. For those thought leaders who have been present during previous restructures, some cynicism remains though, as they've experienced various different policies, which they believe to be a cycle of centralisation followed by decentralisation, spanning back to the days of the PCTs and before.
As we have seen over the last few years, greater centralisation is only a prelude to more localisation. So, I do think the pendulum will swing back in due course, and there will be more borough and local representation. But right now, centralisation is the theme.
We have a tendency to just keep going around in a circle. So things that were popular 10 years ago then become unpopular. And eventually, if you just leave them long enough, they're like flares, they will come back in style again.
Yeah. So probably in another 2 years, you'll start hearing the rumblings of the next transition.
NHS organisations have traditionally been highly protective over their budgets, as each organisation is held accountable to achieving their individual annual financial plans. So as a result, they've caused significant barriers to achieving goals as a system, as parties can be unwilling to contribute their full budgets, but still expect an equal say. Now, payers hope for a combined ICS budget that all partner organisations will draw from to achieve their streams of work. But this does raise concerns over accountability. This would certainly help overcome any competitive issues between partner organisations, but the NHS is so entrenched in this way of working that this cultural change is a significant challenge to implement.
They've been talking about is that you just have the one budget.
Yeah.
Because then you haven't got this, well, actually, should be in your budget, or we're not paying for that.
For me, one of the key issues about does an integrated care partnership work is when the acute trust puts its hand in the pocket and says, oh, I can see there are difficulties over here in community services or primary care. Here, have some of this.
Yeah.
And that is still, not happening.
Yeah.
And if anything, other parts of the system are being are being starved a little bit in order for the acute trust to get on with it. In a way, it was ever thus.
Yeah.
But I suppose, leaving aside the financial austerity that we're going into, I think it will take a bit more time for everybody to say, okay, I've got, my budget is 50 million, I'll put that in the table. Your budget is 100 million, you put that in the table. Your budget is 30 million, you put that in the table. Now let's work out how to spend it. I think that is still some way off, although I think in some parts I can see, people beginning to understand that might be a way of beginning to think about the problem.
The NHS's proposed purpose of ICSs is to bring partner organisations together to, number one, improve outcomes in population health and healthcare. Number two, tackle inequalities in outcomes, experience and access. 3, enhance productivity and value for money. And 4, help the NHS support broader social and economic development.
They come out with sort of like their ambitions to sort of improve the health and well-being of the population, overall quality of care and life, and improving the effective utilisation of resource. So I suppose those are sort of the main things that have sort of come out. And I suppose sort of if you're looking at use of medicines, it's sort of trying to look at sort of quality and safety culture around the use of medicines. So we're sort of trying to work, to improve with them patient outcomes. And then you're sort of looking at unwarranted clinical variation. So you're trying to reduce that with medicines and looking at equitable access. Again, I say working in collaboration with your system partners and trying to sort of, I suppose, gain the maximum benefit for what you're spending, really.
Now, the ICS leads that I spoke with are broadly aligned with the purpose of the ICS, but some have reservations about how they can support social and economic development within their populations. So the main benefit that virtually all highlighted is the ability of ICS organisations to work and make decisions at scale and therefore use collective power as a positive means to leverage further efficiencies within the system. Now, significant opportunities exist for ICSs if they can industrialise and standardise.
The foundation principle of it is it's better to do things at larger scale and make decisions at larger scale by working with partners from local authority than it is by operating your leadership at smaller delivery groups like places. Places would be size of a CCG or 2 CCGs. That's the principle of it. You raise everything up to a higher level.
Yeah.
You make your big buying and commissioning decisions once across multiple geographies, and you get industrial scale benefits from doing that. That's the principle of it.
Scale scale is exciting. It's got opportunities, and there are economies of scale for workforce and recruitment and career development and so on. But scale is also a bit of an enemy of delivering tailored care, and easily risks becoming a bit of a faceless bureaucracy.
Secondly, the ICS structure promotes a system-wide view when applying logical, scientific approaches of how to get things to work better.
Probably the biggest challenge for most health and care economies in England is how do you deal with frail people.
Yeah.
It's not people like you and I. We might get ill every now and again, or you might sort of fall off your back and break your wrist. It's not that type of thing. It's mainly, not always exclusively older people, but mainly older people.
Yeah.
Who get to a stage in their life where they aren't sustainable on them by themselves, and they just things happen to older people that don't happen to younger people. So they get ill more often, they break things more often, their infrastructure collapses. Now, that is the biggest problem, because at the moment we've got no structured way in which we approach the care of that very, very large cohort of people. That cohort of people consume around about 65% of all care resources in England. So if you're over 70 and you've got one or more chronic condition, you lump all those people together and they consume 70% of all the taxpayers' resource in the health service. And yet we don't have a structured approach to how we mitigate the risks of those people. We've tried, but never succeeded. So by working as an RCB, together with local authority, we could say, right, okay, we know what the biggest problem is. The biggest problem is this cohort of people who, if they've got good care infrastructure, we might mitigate the year of care cost reasonably well. If they haven't, we're all going to spend a fortune. So they're going to go to hospital 6 times a year. Every time they go in, it's going to cost a fortune. We can't get them back out again. Eventually, they will need to go into a residential setting, and that takes ages. And we've got bed blocking and all that sort of stuff. Add it all together, costs a fortune. So how would we manage that cohort of people better? By combining our wits and our money and our resources and people, and structure a year of care plan for every single one of them that's industrial scaled. So it's not completely individual for each one. The platform is exactly the same. It's just got some nuances. So we don't have to think every time we get somebody like that who enters the system, what do we do with this person and make it up as we go along? It's all pre-planned.
So this new way of working as a system also enables innovative ways of delivering care for the community. And the NHS has proven time and time again that necessity can be the mother of invention when resources are scarce.
It is a sort of new start, and it's up to us to make what we can of it. And shortages of money often bring out the best at the NHS of thinking about how do we make, what little we've got go further. I think there are some big planks emerging. Health inequalities, the variation in clinical outcomes, and beginning to think about communities as groups of population that, so not just thinking about a borough and a local authority and a joint strategic needs assessment, but beginning to say, okay, each local authority has 10 major communities, which may be geographic, but may also be cultural, may be economic. How do we respond to those different needs? And some of those communities will overlap, of course. So, right now, part of winter planning, of course, we're thinking about, well, how do we provide warm spaces for people? at risk with their energy bills. What else could happen in that warm space? Could there be health advice? Could there be benefits advice? And how do we make those messages to communities more relevant?
Let's talk a little bit about population health management, as population health is a term you'll frequently hear bandied around with ICSs. So it's certainly not a new idea, but it's a core strategic aim of the ICSs. The problem is not everybody is exactly sure what it means or what it truly involves.
I think population health management means lots of different things to lots of different people. One of the problems is a common definition. I mean, I think for me, it simply means understanding your communities and your local populations in more detail.
Our health system has traditionally been based on being a reactive service focusing on individual conditions. Now, ICSs aim to embrace a proactive approach by identifying and engaging with those high-risk groups earlier and bringing them into the health system.
With proactive care comes preventive care, which we've talked about for an awfully long time and have done bits of. Maybe, again, when finances are tight, maybe we can start doing a bit more of that and building on what we've all done already through diabetes, or obesity, or respiratory, or child oral health, or whatever.
Now, prevention being better than cure is a fundamental principle of healthcare. And as an example, in a population health management context, adults and children who live in cold, damp housing may be more susceptible to developing respiratory problems over future years because their lungs can be affected by mould. Now, if their housing situation could be improved earlier by working with partners such as local councils and housing associations, they may not end up with health conditions such as asthma, chest infections and other respiratory problems in the future, which can result in poor quality of life. Now, understanding the social factors that contribute to these comorbidities within these populations could avoid the need for multiple health and care services, which in turn helps address health inequalities. So all ICSs will continue to be responsible for and developing their own governance approaches to ensure strategic medicines oversight. So from what we've learned through the thought leader interviews is that the method by which new drugs are considered for formulary acceptance, so those which have received a positive NICE technology appraisal, is not going to drastically change under the ICS structures. Now, medicines optimization teams will continue to evaluate, provide formulary recommendations around new drugs, as this function is well understood and was proven to work under the former CCG structures. However, the merger of CCGs and harmonisation of medicines optimization committees has helped address local inconsistencies and therefore helped to start tackling some of those regional inequalities. Which committees within the ICS structure now will now decide on the level of access that drug has within the system? And how is that going to, and has it changed?
That won't change. That'll still be through the area prescribing committee.
So there's no change from how it's been going through, in terms of the CCG structure. So it'll go through the area prescribing committee.
Yeah, I think because I suppose for us it's been sort of a lot easier because we've always been very collaborative with sort of our acute partners and mental health partners and community trusts as well. Is that, and it works and everybody knows how it works. So that's not sort of likely to change.
So for us, there was pretty well a single joint formulary between secondary and primary care for some time, even with separate CCGs. That was continued when we became a single CCG, and I guess that will continue more with an ICB. I think there will be discussion certainly about high cost drugs, and how those are managed as an ICB. There'll certainly be more savings squeezed out from the medicines management team, both through the formulary and looking at pathways.
So with medicines and technology accounting for over 1/5 of all healthcare spend, these more centralised medicines optimisation teams will be expected to make further savings through the ICS formulary and actively review existing pathways. They'll also create new pathways in areas where they don't currently exist, again to help address and reduce inequality and variation. There are even further possibilities for multiple ICSs to share formularies in the future and even procure treatments at an even greater scale.
I think the change will be towards more centralisation, certainly more standardisation and squeezing more cost out.
Another key function they're responsible for is monitoring prescribing habits, including the use of high-cost drugs through the BlueTech approval system. This helps to ensure that high-cost interventions are being used appropriately within the local health economy. They will also keep abreast of new innovations through horizon scanning techniques, and this keeps the ICS updated about new technologies that are expected to break through in coming months. Now, the Medicines Optimisation team are integral to the Area Prescribing Committee, or the APC, along with representation from GPs, consultants, hospital pharmacists and community pharmacists, amongst others. And these act as a strategic pillar for the ICS. So they deliver cost-effective and evidence-based prescribing across the local health economy, updating medication pathways to support continuous improvement of patient outcomes. Now, the APC or equivalent will report to the ICS board on typically a monthly basis to inform them about those drugs which are under consideration, any changes to the formulary and any areas which require equalisation. So what all of this means for pharmaceutical companies is that they really need to engage with each of these groups to influence which drugs are selected and then ultimately commissioned for use across the whole of the ICS. So as part of understanding the positioning of their medicines to these ICS groups, decision makers or even influencers, GKA is able to help undertake DFUs to ensure messages are resonating with those key decision makers. To wrap up then, some of the things that really stood out for me and will have an influence on medical market research are, firstly, that the ICS reform programme hasn't arrived overnight, and whilst different regions are at different phases of implementation, the CCG infrastructure has given all areas a strong foundation, making the impact more transitionary rather than revolutionary. Secondly, the statutory integration of health and social care starting at government level should improve outcomes for patients and in time ease pressures on the NHS, especially in the area of bed blocking and the upstream impact that has. Also, the integrated budgets will enable regions to focus on local priorities but achieve greater efficiencies by operating at greater scale. Population health management, whilst still in definition phase, ultimately aims to look at preventative, circumstantial, holistic and social economic impacts on health. And most significantly for all of us involved in healthcare research, it will mean that there's now new emerging roles that will need to be added to the payer portfolio, bringing insights at a system, place and neighbourhood level. So integrating services will increase insights on the whole person and healthcare, and preventative and general population research will support the identification of commercial opportunities for device manufacturers and pharma. So whilst we are still in the early stages of the ICSs coming into force, we can envisage that even with a change in political leadership, it's very unlikely now that we'll see a decoupling of health and social care as a way to improve health efficiencies, drive innovation and create better connected patient journeys. Thank you very much.